Zimbabwe is a Southern African country with a population of 14 million. The GDP is $5.6 billion. In Zimbabwe has got an HIV prevalence rate of 13.7 million. As a 30-year-old woman who with advanced cervical cancer had this to say, "Doctor, I wish I had HIV, then I would have free treatment." This was a reality check on the magnitude of suffering of our patients. Imagine, every 2 minutes, a woman somewhere in the world dies of cervical cancer. 500,000 are diagnosed each year, many of them in the developing world. A disproportionate number of these deaths occur in Africa, particularly in Southern Africa. This number of cases is equivalent to the number of cases in Northern Europe before the discovery of the pap smear in North America in 1930. Cervical cancer is caused by a human papilloma virus. It is a preventable cancer, not yet preventable in Africa. It is a disease of inequities in access to health care. It is indeed a neglected tragedy. It is the most common cancer among women in Africa. It is the most common cancer in Zimbabwean women, accounting for 32.4% of black Zimbabwean women. The age standardized rate for this cancer for 1998 to 2002 was 47 per 100,000. The topmost 5 cancers, except for breast cancer in Zimbabwe, are all HIV associated. The peak age at presentation of cervical cancer is 40 years, which is much less than the 50 years in the developed world. This means that these women of childbearing age with children who are school-going, the impact is far much greater. Also, these women are at their peak of economic productivity. It takes approximately 10 years for cervical cancer to develop. And ladies and gentlemen, we have got a large window of opportunity, but we keep on dragging our feet as if it will never happen to me. Cancer issue is relevant to each one of us. With comprehensive cancer care, we can always say to everyone that there is always everything that can be done for cancer. For those without cancer, we can be able to prevent cancer either through health promotion efforts or through prevention using vaccines. For those women who are much older and they have already developed the pre-invasive cancer, we can actually prevent cancer through screening, and this can be done from the age of about 30. Those with advanced disease, invasive disease, we can actually treat them through various treatments, and the cure rate is better for the earlier the disease is. Cervical cancer and those with advanced disease, we should always remember that we should give them palliative care. So the treatment modalities for invasive cervical cancer include surgery, which is relevant for those with early disease, and then, unfortunately, with surgery, most of our patients present with advanced disease. Therefore, they are not amenable to surgery, and it means that if we try to operate them, we cut through the tumor. We also have a shortage of gynecological oncologists, and for us to perform good surgery on patients with cervical cancer, we need gynecological oncologists. Then treatment that is relevant to most of the patients with cervical cancer is chemoradiation. That means chemotherapy given concurrently with radiotherapy. This has been shown to be the most effective type of treatment. And unfortunately, radiotherapy and chemotherapy are not accessible to many people who live in Southern Africa, particularly. Palliative care is relevant to many of the patients who present in our environment with advanced stage disease. Palliative care means we are relieving the symptoms of the patients. And when we relieve the symptoms of the patients, we are trying to, one of the symptoms that should be relieved is pain, and morphine is the drug that we should use. And in most cases, we find that morphine is not readily available. Chemotherapy drugs are not readily available. The prognosis of cervical cancer in our environment is poor. This has been shown by a study which was done locally from 1995 to 1997. We showed that 44% of our patients who had been treated only survived for 3 years. This poor prognosis was due to advanced stage disease at presentation, concurrent diseases such as HIV and malnutrition, and also limitation of resources. The challenges that we face in cervical cancer care are many. These challenges are actually difficult, because most of the challenges is due to the fact that cervical cancer in general is a highly stigmatized disease. In fact, many people, the attitude is a big problem. This includes the attitude of the patients themselves who have got the disease, or even people who do not have the disease because they think they will never get the disease, attitude of society in general, and even the attitude of the health workers. You find that some of the health workers are not very keen to come and work in the cancer area. So these challenges make it very difficult even to actually advocate for funds for cancer management in terms of prevention, treatment, diagnosis, early detection, and palliative care. Human papilloma virus vaccine offers some hope in the management of cervical cancer. In Zimbabwe, we have got guidelines for cervical cancer management, and unfortunately, we do not have the vaccine yet. However, vaccine registration is ongoing. The cost of the vaccine raises concerns on the sustainability of vaccination programs. In conclusion, ladies and gentlemen, cervical cancer is a leading cause of the morbidity and mortality in our environment. Scaling up screening to treat pre-invasive cancer will save some women now. Vaccination can prevent cervical cancer and offers hope for the future. Meanwhile, we are obliged to offer palliative care to the many patients who are presenting with advanced disease. Lance Armstrong, the famous iconic cancer survivor, said, "Knowledge is power, but attitude is everything." Ladies and gentlemen, with the right attitude, we should be able to eradicate cancer one of these days. And before I leave, I would like to throw a question to all of us to say, for how long are we going to let our women continue to die of this preventable disease? Thank you, ladies and gentlemen.